spending their days in the clinic. I will now pass it over to our final pair of committee moderators, Ashley and Connor. Take it away, guys.
Thank you so much, Ryan. And thank you everyone for joining us for the final panel of our sub-internship summit on how to excel in the clinic. My name is Ashley Rosenberg and I'm an M3 at Mount Sinai. I'm joined by Connor Littlefield, who's an M3 at the University of Iowa. We'll be co-moderating this panel. We have an incredible set of 5 panelists today with a ton of wisdom to share on how rotators can show their clinical competency and efficiency while working directly with faculty. So Connor will be introducing them all to you in a moment, but first I just want to briefly outline the plan. So we're going to ask a series of questions over the next 15 minutes, and then we're going to leave some time for questions in the chat, but feel free to drop them as you've been doing this whole day. So once again, thank you all for joining us, and I'll pass it over to Connor.
Thank you, Ashley. Here are our 5 distinguished panelists for this panel. Dr. Megan Kelly is an assistant professor of orthopedic surgery at Mount Sinai, specializing in foot and ankle surgery. She's involved with the American Orthopedic Foot and Ankle Society, serving on the health policy and humanitarian committees, and is a member of the Ruth Jackson Orthopedic Society. She also has a background in basic science research, having earned a PhD in physiology and biophysics prior to starting medical school. Dr. Ryan Rock is an assistant professor of orthopedic surgery at Ohio State University, specializing in sports medicine and shoulder surgery. He's a team physician for Ohio State's football team, and his research interests include improving our understanding of shoulder instability, as well as patient expectations and clinical outcomes for shoulder replacements and rotator cuff repairs. Dozie Ekweriri is a PGY2 at Loyola University Medical Center. He attended medical school at the University of Kansas School of Medicine. Anne Marie Leonard is a PGY2 at the University of Nebraska Medical Center. She attended the Northwestern University Feinberg School of Medicine. Emil Agarwal is an M4 at the George Washington School of Medicine. He is a co-founder and the current president of MSOS. He will be starting his residency training in orthopedic surgery at Hopkins in July. Thank you to all of our panelists for volunteering their time to share their advice with us today. With that said, let's get into the questions. And panelists will be addressing the questions to 2 panelists at a time. However, please feel free to jump in at any time and address any questions that may not be directly addressed to you.
Okay, so for our first question, which is going to be for Dr. Kelly and then Dozie to start, what qualities or characteristics do you look for in medical students on their orthopedic clinic days?
Thank you so much. And thank you for giving me the opportunity to take part in this. I do think it's very important. I think that while we're applying to, we are in a surgical field, we do spend a lot of time in the operating room, but as you'll likely discover, we actually likely from an hours standpoint, we likely spend more time in the clinic seeing patients, and you interact with 20, 30 patients a day, sometimes more, versus OR days, it's only 2 or 3. So it is important to, get what you can out of the ability to be in the clinic and learn what you can with interactions between the attendings and their patients. So I did get a chance to listen to some of the previous discussion about what kind of qualities you want in the OR. And I will say there's actually a fair amount of overlap. You really want to demonstrate your enthusiasm. And I know it's a little hard because in some cases you kind of have to hold back a little bit, but demonstrating enthusiasm and preparation. Obviously, you're not going to know what every patient comes in with every day. That's the joy of being in the office, is it's a lot of new stuff and you never know what's going to walk in. But just basic knowledge. And I think that especially when you're first starting the rotation, be a sponge. Just grab every kind of information you can, and be a sponge and be very observant. See how the attending interacts with patients. If they have residents, how the residents interact with patients. I think you can learn a lot from those just those general interactions in the office that can be translated to other parts.
And then I'll jump in here. I think I'll echo a lot of what Dr. Kelly said. I think the first and foremost, like she said, is you have to have a good attitude when you're in clinic. I think that it's very easy for everyone to get excited about the operating room and the instruments and things along those lines. But clinic is usually a point, and I can tell you as a PGY2, it's a point that it's easy to lose enthusiasm. So you really have to keep your cap on and make sure that you are learning from each experience that you get to have as a rotating student. I think that you're also come to know that you can learn so much from your patients if you just listen, and it helps you with all the disease processes that you're trying to learn as a student. And if you are able to tie those processes to like a certain patient that you met in clinic, it helps you a long ways in regards to learning those things. I'd say also just overall being a good listener and kind of keep feeling the vibe of what clinic is going like. Some attendings like longer presentations, some like shorter presentations, but understanding that if you have a 50 patient clinic and it might not be the time to have a side conversation with an attending. So just kind of having that, I'm sure it was discussed in the last panel, is just having that wherewithal to know your surroundings and know what's going on. But I think first and foremost, just having good enthusiasm and listening to your patients are the two biggest qualities you can probably have in clinic.
Wonderful. Thank you for those answers. Our next question is for Dr. Rock first, and then for Anne-Marie. In your opinion, what distinguishes a successful orthopedic surgery sub-I student in the clinic environment?
Yeah, so I think everything that was just mentioned is very important, and agree that there's a lot of overlap between the operating room and the clinic as far as what we're looking for. But in general, I think when you first start on a rotation, just really being that sponge and kind of understanding how people run their clinics, because everyone can do it differently. You know, a 50 patient clinic is a lot different than a 15. So really just soaking it in that first week or a few times to observe and kind of anticipate where you could help things run smoothly, or more importantly, you know, if you're behind, when, you know, not a great time to start asking really detailed questions about pre-op planning, but when you have those down times, being able to ask those questions. Because I do think being interested in kind of asking questions relevant to the patient's exam or imaging or surgical planning go a long way. You just have to be cognizant of the timing for asking those. And then as people progress along and you start seeing patients on their own, I think the biggest thing, it's not a lot of what's been mentioned, it's not so much a test of your knowledge, it's more of a personality test on the sub-I. I think what can be helpful is when you examine a patient to give a coherent presentation, and then also just kind of have a differential to show that you're at least thinking about what's going on. I don't expect that sub-Is are going to know the answer to everything, but at least show some thought process of you know, thinking and trying to learn on the rotation.
To add to what Dr. Rock said, I think for students prepping the night before for, you know, what's coming into clinic, you know, you will likely know which clinic you're going to be a part of, and then looking up that attending specific schedule and, you know, what's coming into clinic, so that can kind of guide your reading the night before, so you can ask more thoughtful questions when you're in clinic, or you know, seeing patients at the appropriate level of independence. You know, if you've prepped for them, you will be able to reach that level of independence sooner in clinic, and, you know, help yourself fit into the flow of an efficient clinic sooner, which is sometimes very hard to do as a sub-I and as an away rotator.
Thank you so much, Dr. Rock and Anne-Marie. You definitely touched on some things that we're hopefully going to dive even deeper later in the panel. So this next question is for Dr. Kelly first, and then Dr. Rock. Should medical students expect to see patients independently in clinic, and how can they show that they're ready to see patients independently?
So I would say right off the bat, and I might be a little bit more casual in this situation, I would not expect medical students to necessarily see folks independently, especially early on in the rotation. I think it kind of depends on how the rotations were set up. I know when I did sub-Is, there were some cases where we did 2 weeks on one service, 2 weeks on another. Then we were doing 4 weeks on one service. So I think when you're with someone a little more consistently, you know, you can progress to that point. I think one thing that can be helpful is asking, even touching base with the residents or medical students that have worked with that particular attending in the past. Because I think everybody's going to be a little different, so you kind of know what to expect. You know, yes, you guys are learning, but you also have 5 years of residency to learn. And you know, my residents, I expect them to see them people independently, but I think that for med students, I you know, if you've been with me a couple times and you want to see someone independently, that's totally fine. I like to think I'm relatively approachable. So I've had people just ask me, hey, can I see this next patient? And I'm not gonna lie, if I'm behind and I have 3 patients waiting to see me, I'm cool with that. Go see them, then I can catch up on some of my other stuff. And it gives you an opportunity to kind of, you know, demonstrate your skills. As well. So it's a little bit of knowing the environment. It's a little bit of knowing the attending, which I think is not the easiest thing as as a way rotator, but I think just demonstrating your enthusiasm and just saying, hey, would you like me to see this person?
Yeah, I totally agree. I think that I also have students start, more shadowing or observing, kind of coming into rooms with me. And then if I get more continuity with them, then definitely having them start to see some patients independently. I don't think there's anything specific as far as demonstrating you're ready, but I have had the same situation where there's a lot of patients that are roomed and a student asks, hey, can I go see this new patient? And it actually is helpful because then you can see a couple follow-ups and catch up a little bit. So I think in general, I wouldn't necessarily expect to see it, especially right off the bat, but every clinic's a little different. So I think if it's an elective practice versus a, trauma or something else, so you just kind of have to see how the flow works and then, adjust from there. But yeah.
Excellent. Excellent advice. Our next question is again, we'll start off with Dr. Rock and then also give Emil an opportunity to respond. And the question is, are there any particular pieces of advice you have for medical students, either when presenting patients to attendings or writing clinical notes? I know there's, a lot of people have different preferences and things that individually they like to hear or see. So any other bits of advice along those lines?
Sure. I think what always impresses me is when students give, concise presentations, but if I have questions, they know the answer. So I think kind of knowing everything, but delivering the presentation in a way that you're really highlighting the pertinent things. And it's definitely a contrast from your third-year rotations like internal medicine or, some of the more detailed presentations. Generally, I think most people want pretty short presentations. Again, it's going to be somewhat specific to the practice that person has. An oncology rotation may be more detailed than like shoulder. There's not a ton that I need to know outside of what's going on directly with their shoulder. But I think in general, what serves you well is kind of presenting concisely in an organized fashion and then knowing everything. So if they have questions, you have those answers, but you don't have to volunteer them up front.
Yeah, I would add for the presenting patients too. I think I agree with everything that's been said. I think a common theme that's also been said too a lot is like kind of working and talking to like co-medical students or residents to see the kind of the general expectation of how clinic is run. And so maybe that attending wants a longer presentation, and most of the time, Dr. Rock says probably more on the shorter side of the presentations too. I always think it's a good practice to practice that presentation in your head a little bit. Just, it's not the first time you're synthesizing those words to your attending, so it sounds a lot more like a better flow going in as well. I think too, knowing the attending, also knowing the different patient you're presenting as well. So if you're presenting a new patient versus a follow-up patient versus a post-op patient, it'll be very different presentations. A new patient, they probably want more of that information of that history, but if they've obviously already operated on the patient, a post-op patient or a follow-up, you don't have to include as much of that information. I think you also asked about notes too. I think for notes as well, I think a lot of it, sometimes you don't even write notes too, so don't feel like you have to feel pressured to write notes. But if that's kind of, again, talking to residents and attending or other medical students, and that's kind of what med students do, a lot of attendings and residents already have smart phrases or templates with the EMR. And so I would definitely make sure before clinic, if you get access to those templates, I would start with that. For efficiency, I would sometimes start pre-writing notes too, if possible, based off kind of some of the information there too. So then if like again, if it's a fast trauma clinic, I think someone referenced you have like 50 patients you got to do, it helps kind of the efficiency, and you could show that you, the med student, can be efficient too. And then also, I would say follow kind of what everyone else is doing and where they're writing notes. Sometimes they're writing notes in the patient's room, which is kind of not often, but sometimes that's how their flow is. And so kind of match the flow, what's going on. And maybe that's where you should be writing your notes too. I know a couple of my sub-Is, that's where they did it, or more commonly during doing it in like a common space as well.
Thank you so much for those responses. I think that it gave some really helpful tips. So our next question is kind of our classic question about for Dr. Kelly first and then Dozy. What are some common mistakes that medical students make during their clinic rotations, and how can they avoid making those mistakes?
So I would say, as far as common mistakes, I'm not going to fault you if you went to see a patient and you're telling me what they say, because I'll be honest, this is going to happen. I'm sure it happened in your other rotations, and it's going to happen for the rest of your life. Is the patient will tell you one thing, and then you come out and you tell me, and then I go in there and they're like, oh yeah, and then this and this, and it's completely the opposite. It happens. It happened to all of us as residents. It happened to all of us as med students. So that I never worry about. So just to let that lie. I think some of the mistakes is a little bit of just that lack of awareness that they touched on a little bit in the OR. When things are really busy in the office, and even I think Dr. Rock mentioned this a little while ago, is when things are really hairy in the office, it's probably not the time to ask about, the specifics behind a surgery that may be performed. Or I did have one med student ask me, sometimes it's just the way you word things that can be a little off. Like, it was a post-op patient where I'm doing minimally invasive bunions. The x-rays look really funky. Like they do. It took me a year to get over it. But the student was like, that doesn't look right. Just like, so be very careful, I guess, in your wording if you are going to talk about the x-rays and some of the findings, especially if you're doing that in front of the patient. So again, just a little bit of that general awareness, because again, we don't expect you to be perfect. But you can ask me later when it's not so crazy, and I'd say, yeah, it looks really funky. I know. But yeah, it's supposed to look like that.
Yeah, I think I would echo a lot of that. Definitely do not say that. But
I was like, awkward.
yeah, for sure. I'd say the mistakes that commonly happen, like Dr. Kelly said, uh, if you ask the patient something and they tell you something, they tell the next person something different. That's expected. That happens to literally everyone at every stage of training. But one thing I would say is definitely be honest. So, for example, if an attending asks you what a certain physical exam maneuver was for the patient and you like didn't do that, just be honest and say you didn't do that exam. I've run into students that were like, oh no, that was fine. I was like, well, we're gonna go in there in about 2 seconds and we're gonna do the same thing, and you're gonna be caught up here pretty soon. So definitely just be honest. I think also, like we discussed before, just keeping a good attitude. And most of us residents are extremely approachable and we want to be your friend when you're on service. But if you're like coming up to us and you're like groaning about clinic like over and over again, like those are not good things to be doing. Just keep a good attitude. We're pretty funny people, all orthopedic surgeons, so we're gonna joke around with you, be part of the conversation, be part of the humor. But overall, just I think having the awareness, like has been discussed over and over again, if it's a busy clinic, your presentation should be concise, like one-liner concise, like only what they need to know. And then if they do want to know more after that, like Dr. Rock said before, they'll ask you, and then you be prepared and answer the questions again concisely. That's what I'd say.
Awesome. Awesome. Our next question is kind of along similar lines, about, optimizing performance and eliminating mistakes. The question is for Dr. Rock and then Anne Marie. Can you provide some insight on kind of the balance between being proactive, but also asking for help or seeking guidance from supervising physicians during a clinic day?
Yeah, I think a lot of this overlaps with the OR. I think in general, seeking guidance and being proactive, particularly with the residents that are on service or medical students that were there before, can be helpful. I think often like the attending may have a lot going on. And so asking them a bunch of questions may overwhelm some. I think I personally don't have a problem with it, but I think you just need to be able to kind of establish that rapport and determine if that's going to be your best route. But I think in general, residents are a great resource for kind of asking for guidance, like, hey, how can I facilitate the clinic? But I definitely appreciate when students are proactive. I think a lot of that's what we're looking for on sub-Is. It's just seeing someone that can kind of assess what's going on and then see how they can contribute to kind of anticipate the next step, whether it's the OR or clinic. And so, like, for example, if I'm doing an injection or something and you see that I get gloves and the cold spray or whatever, and then, the next time I do an injection, you get that stuff, or you at least like, try to facilitate doing that, just showing that you kind of understand how you can make things move smoothly. But I think both are reasonable. I think in general, trying to just observe what's going on and think about ways that you can help going forward shows a lot of the traits that we look for in general for residents.
Kind of to piggyback off of what Dr. Rock said, finding ways that you can be helpful in clinic when it is a busy clinic day. If you are writing notes for the clinic, asking the resident ahead of time or on your way down to clinic if there's templates they use for that particular attending can be really helpful. Or asking the resident on the way down to clinic, what are that specifics attending's expectations. Those are all good times to ask those questions early so that while you're, learning early in that clinic experience with that specific attending or that specific team, how you can, integrate yourself well. And that kind of helps you figure out the times where it's more appropriate to ask questions versus, it's not really an appropriate time to ask questions when everybody's 5 to 10 patients behind or whatever behind in that specific clinic looks like. That's not the best point in time to ask questions.
Yeah, one other thing I would just add to that is about the questions. I think a common misconception amongst students is that you need to ask a bunch of questions to kind of show that you're interested. I think really just picking your spots and asking pertinent questions, whether it's a surgery or a patient you're seeing, goes a lot longer way than asking a bunch of questions. And then also we all know the students that kind of ask questions they know the answer to, so they're kind of asking the question just to answer their own question. So I would avoid that as well.
That's a great piece of advice. So for our next question, which is going to be for Dr. Kelly and then Emil, but we're going to ask everyone, you can jump in since this is kind of a really important question. But what resources or learning materials do you recommend that medical students use in order to prepare for clinic? And then how can a medical student best prepare for clinic ahead of time? Like, how do you recommend reviewing the chart before seeing the patient?
So, I'll be honest, I'm probably a little bit out of the loop as far as what types of books and resources are available at this point. I don't know. I remember when I was a medical student, there was that Netter's book that was the Netter's orthopedic book. And if I recall, there was a lot in there on physical exam maneuvers, which I think that's kind of important to know what you're kind of getting into, because as Dr. Rauch would point out, there's a lot of things that he does in the office that we didn't learn during medical school. And the same thing with me. A lot of the foot maneuvers that I do, a lot of the stuff that I do to describe the foot and ankle and looking at stability and some of the provocative maneuvers are not something that we learned necessarily during medical school. So having a little bit of that background going into it, the AEOS Yellow Journal I always thought was really good for some nice, concise review articles that are comprehensive and are written. I mean, even though they're written like they're actually written for the generalist. So they're written by specialists, but they're kind of written for the generalist. So having that as a resource, especially if you know you're going to be on like a foot and ankle rotation, kind of look at the specifics as far as physical exam maneuvers go. And let's see, I'm trying to think. that's kind of the main, I would say the main thing. There's lots of videos out there now too that talk about physical exam maneuvers. I don't expect you to know how to do them all. In fact, that's one of my favorite things to do, is to demonstrate, like especially Achilles ruptures. There's all sorts of stuff we can, fun little tricks we can do to show those, to demonstrate that on patients and get it that way. What was the other part of your question? I'm so sorry. Let's see.
I was
Really just the best.
asking about-
Oh, the medical records, sorry.
Yes.
So medical records, I think it just depends on what your access is. I don't know if we always have, our medical students have access to the medical record ahead of time. Just reading, just kind of checking in. Mine, the way our Epic is set up, where you can see whether it's a post-op follow-up or a new patient. So obviously new patients aren't going to have a lot of background. We get x-rays when they come into the office. So there's not often a lot in that as far as preparation, unless they were recently seen in the emergency room for like an ankle fracture. So sometimes your guess is as good as mine of what we're going to see when they come in. The way I design my notes is I just forward like the prior notes. So like my history looks chronological. So you actually don't have to go back, the 10 visits I saw them previously. If you see the most recent note, it'll have that daily or that weekly or that monthly difference between the patients. So, that's just the way I design it. So it's a little bit easier to review. So, it's easier from if you're coming in cold as well.
Yeah, I would say for me, I agree with Dr. Kelly. A lot of the resources that you said is actually the resources I used. One I definitely utilize the most is probably OrthoBullets. OrthoBullets is great because both you can learn general pathology. Also, a lot of the times they actually have articles on like shoulder physical exam maneuvers or something. So you can go through those and see them. And what's nice is they sometimes pair it with pathology so you can know when to do it. And then looking at videos, YouTube was a big friend for me too when I'm kind of going in, just making sure I know how to do these maneuvers. And then as Dr. Kelly says too, if you haven't done the maneuver before, it's also really nice that the attending will probably go through that, or the resident will go through that and teach you. Those were the general resources that I used for clinic. For preparing for clinic, I did, that what Dr. Kelly said too is very true, in that some clinics you get more information than others. Maybe you do have access to the EMR beforehand, and so you can do a lot of work to help prepare yourself. Kind of the similar sense that people have brought up before, I would kind of get some background information from residents and co-med students to know the expectation for clinic, such as, do you know if will you be seeing patients on your own? Are you expected to write notes? Are you sometimes you don't even present the same patient, in the sense that maybe the attending is telling you you'll only see new patients and you're not going to look at our post-op and follow-up patients. And just knowing that makes it a lot easier to know, because you have limited time as a med student. You come home after cases, you're tired, you want to prepare for clinic. And so what I kind of did once I gathered that information is then I kind of prepared accordingly. And so if I do have access to the EMR and I know what patients I'm probably presenting, I kind of went through the patient list the night before of those patients, whatever information that I have, and kind of generally reviewing those, especially when it was early on and I've never worked in that kind of clinic capacity beforehand. A lot of times you'll see for new patients, it's just going to be a new patient on like Epic or something. You're not going to get much information from there, and that's totally fine. You could also just in general know, if you're on a joints clinic, it's sometimes a little bit easier. It's only usually hip and knee pathology. And so going through those kind of OrthoBullets in general to get an understanding. Sometimes in trauma could be a little bit difficult because it could be trauma in any extremity, and that's totally okay. And so having that general understanding, and a benefit too of reading a little bit beforehand is you could kind of minimize the amount of time you're on your phone looking at OrthoBullets. I would recommend in general in clinic, try not to be on your phone. You may be like studying as much as you can, but could perceive that you're just like, maybe you're on social media. And so having that understanding. And then two, you could prepare more like intelligent questions to ask as well. Clinic is a great environment to really be exposed with your attendings in like a one-to-one scenario. Sometimes the OR could be a little bit difficult. And so you could ask more intelligent questions rather than the first time coming to hand clinic and being like, what is carpal tunnel syndrome? That's probably not the question the attendings want to hear from you.
Thank you both for your responses. Those are really helpful tips, I think. Our next question is for Dr. Rock and Dr. Kelly. We've spoken, throughout many of the panels today about, some important soft skills and things like that medical students should try to display on their sub-Is. Can you talk a little bit about how medical students can try to develop relationships with both patients, but also other orthopedic clinic staff to try to and create a positive learning environment?
Sure. Yeah, I think very important to introduce yourself to everyone. So and I wasn't on there for the whole OR conversation, but I imagine it's kind of similar, like introducing yourself to the circulator and the scrub tech and everyone in the room. Same in the clinic. I think, the checkout staff, the MAs or whoever's doing the rooming, they see a lot of medical students, and they also, their opinion does count for quite a bit because, and I heard someone allude to it earlier, but if you don't treat them with respect or you're not nice to them, it definitely is some red flags for what's going to happen if you're then, a resident or in the program for 5 years. So I think going out of your way to really introduce yourself to all the staff, be super friendly. Kind of the sub-Is are tough because it's basically like a month-long job interview, but unfortunately that's kind of the reality of it, is that really treat everyone like they're interviewing you. And so I think that's for the staff. For patients, I think it's just kind of same thing. Like, for me, it's like helping them get a sling off or on can be, a nice way to establish rapport. Listening when you're doing your longer history than we typically have time for, stuff like that will go a long way.
Yeah, and I would echo a lot of what Dr. Rock says. It's kind of the idea of just be nice and listen. It seems simple, but it really does go a long way. As far as helping the MAs, like, if an MA is taking dressing off, like I usually will tell the MAs ahead of time if I know, my patients want their dressing off, and things like that, or they're splint down or something like that. And going in and helping them can kind of go a long way, as far as assisting. And patients, and again, patients love to they're so used to not having people listen to them. So, even just letting them talk for, they say what the average is, we interrupt every 11 seconds or something like that. Letting them just kind of get their story out there does a few things. One, it often will answer the pathology for you. Frankly, I've had a lot of patients that just diagnose themselves as their conversation continues. But it also gives you the opportunity to, listen to them and develop a little bit of rapport. And those are the patients that, I'll come in the room and they're like, oh yeah, you got a great med student here. They were wonderful. Even if all you did was just sit there and listen.
Thank you so much, Dr. Kelly and Dr. Rock. Those are super helpful, like tidbits that I know we're all going to use going forward. So for our next question, which is for Dr. Kelly and then Anne Marie, can you share any memorable experiences where a medical student excelled in a patient interaction in clinic?
So I kind of answered this with the last question, but honestly, it's generally been that if I walk in the room and the patient is just like, oh, you're med student, I usually thank them for talking to either, my med student, my resident, whatever. And, just the ability of them being able to speak has been really helpful for the patient. And my thought is, if they're going to treat patients that aren't their own like that, then, again, they're going to do much better when it's their own patient. And I've also had some medical students that have just been wonderful with the team. Again, it's a team sport. Just because I have an MD after my name, doesn't mean that I'm, any higher. I'm just the quarterback, and we're all members of the same team. And you need a good offensive line if you're not gonna, get intercepted or get tackled. So I mean, you need kind of everybody. So those that have been able to kind of engage with my MAs, engage with my residents, and really work as team members have been the ones that have excelled both in the OR and in the office.
To build off of what Dr. Kelly said, it's the students that tend to stand out are the students that came clearly prepared. They asked intelligent questions. They gave succinct presentations, but, oftentimes you'll give a succinct presentation and then either the resident or the attending will have some further questions for you. and it's the students that either know the answers to those questions, or maybe, you know, in a particular situation you didn't know because you haven't seen that pathology before, but, you know, then a subsequent patient interaction, the students either offering that in their presentation, because that's obviously something that specific resident or attending cares about. It shows me that you're paying attention in clinic, or in whatever clinical setting we've encountered that before. And those are always the students that tend to stand out, in addition to, you know, working well with the entire medical team, not just myself and my co-residents and my attendings, but working well with, you know, all the other people who help us take care of patients, and, you know, we're all friends with because we all work together.
Wonderful, wonderful. Thank you all again for your great responses. Our next question, I know we had touched a little bit on this earlier, so maybe you can talk about, you know, some of the procedures in clinic and things like that, but how can students, you know, demonstrate initiative and showing off some of these skills, maybe like suturing or casting or what might happen in clinic, without like being overbearing? And oh, sorry, I was
So
just
for
going to
me,
say it.
I think this question, I can't remember if this one was for me, but there's no specific skills in my clinic per se, but I think in general, a lot of sub-Isaac, you'll do some trauma. So I think the same way you help out a resident in the ER if they're splinting, just kind of getting supplies, doing stuff like that. But it's going to vary a lot depending on the practice. And maybe Dr. Kelly, you know, with more splints and casts, has stuff students can help with. But for me, no, there's no specific skills I'm looking for in the clinic.
Yeah, I would echo that. I would say the same thing. Like, in general, we're not putting splints on as much as we are taking them off. So, you know, you can help the MA, but I don't expect you to know how to splint. That's what residency's for. Same thing with suturing. I mean, I don't really suture in the office. So, you know, there's been rare circumstances, but in general, you know, things like injections and, you know, and even Dr. Rock kind of touched on this before, you know, showing that initiative. So knowing what kind of stuff I pull when I'm about to do an ankle injection, knowing that the freezy spray is nearby and the gauze is nearby, that stuff goes much longer, much further with me than anything else, because like I said, I don't expect you to suture in the office. And just from a procedural standpoint, I don't do that much in the office that would require any like specific skills.
Yeah, I was gonna say actually what Dr. Kelly said about, like, I feel like steroid injections are a very common thing I saw in clinic. And so having the supplies ready to go, being ready to put the Band-Aid on, it sounds like a really subtle, small thing, but being able to predict the steps, I think, are really helpful. But I think the most common thing for initiative is really kind of just seeing like where, like, it doesn't have to be with skills to be ready to help prepare, but it could be more like offering in the beginning of clinic, be like, I'd love to see patients on my own, and giving that, if you know at the 50 patient clinic, you know, that'll probably be helpful if you gather that history, you can present it. Offering to help with notes. Sometimes also students may not be good at notes, and maybe it actually won't be productive. And then also being understanding that if they say no, don't help with notes, don't be too pushy and be like, no, I really want to help out with notes. So kind of reading the room to see how you can be helpful. But I don't think special skills, like, you don't have to like set up a cast on any of a patient. If anything, if you're doing like a peds clinic and they're doing like serial casting, the attending probably wants to do that more than have a student doing it by themselves.
Yeah, no, those responses definitely make a lot of sense. And that tip about just like getting all the materials ready, knowing like when a piece of gauze is needed and just having that open and ready to go, that's like super helpful. And so for our final question, which is going to be to all the panelists, what is one last piece of advice that you would give to applicants this cycle? We can start with Dr. Kelly and then Dr. Rock, Dozie, Anne Marie, and Emil.
So, I mean, I feel like this has been harped on, but I think being prepared and being kind, will go a long way. Let's say, and we can add be humble. So being prepared, being kind, and being humble, those three things will get you exceedingly far, along with being a sponge.
Yeah, I totally agree. I think the fact that you guys are all on this Zoom call, shows that you obviously want to do a good job and are interested in kind of how to be successful. So I think it's not anything about like really knowledge base or I mean a little bit, but for the most part, I think what everyone has said is this someone that you want to be around for 5 years? It's an extremely stressful 3 to 4 months to kind of do all these sub-Is. And so I think we all kind of get it. We've been there. And so I think it's, you kind of get through those months and you're like, geez, but I think the more you can kind of just view it as an opportunity to, unlike the rest of med school, I mean, you get to spend a couple months doing orthopedics, but now you'll get to do 4 months of, getting to see 3 or 4, meeting different programs, seeing different people, kind of viewing it as that opportunity to spend time doing what you're going to do for the rest of your life, and can be helpful, and really not stressing too much about that the patient tells you something and you tell the attending and then they change their story. Like, we've seen all of that. It really is more of just the personality traits that we're looking for. And so I think just the like being available, being affable, and being able, kind of serve you well in all aspects of life, but particularly as you go through these sub-Is.
Yeah, I think I would agree with what everyone has said so far. I think having a great attitude is probably the best thing that you can do, especially like in clinic, but just overall, the 3 or 4 months of away rotations it's going to be a lot. It's going to be hard on you. And I think leaning on your support system, if you have mentors from different institutions, just talking with them about what you're going to do for the next 3 to 4 months, I think is really important, especially if they have specific experience at like the institution that you're going to and can provide you with some information about that program specifically. I think that was very helpful for me, at least when I was going through. My mentor had someone at that institution that I was rotating at, so was able to kind of provide me with some information before I got there that helped me out a lot when I was there. So just go ahead and lean on your support system. It'll go a long way for you as you prepare for the next 3 to 4 months of away rotations.
To build off of what everybody else has said, there is a lot to learn, be eager to, continue learning and continue improving in every single aspect of your training. These are the first 3 to 4 months that you will get to spend in your medical education, learning orthopedics and learning the best specialty that we are all very biased in medicine. And that is, while it is a challenge, it's a very exciting challenge and important next step in your career. And don't, lose the forest through the trees, as we always say. Continue to get better. We all make mistakes and, find ways to improve from those. And that's a really important spot in your learning. And best of luck to you all.
Yeah, I would say the last thing I could add, I think everyone said exactly what I would probably say, but the one thing would be just take care of yourself. It's a long, like, this is a marathon, not a sprint, just like residency is as well. So find the time to make sure you're eating food, make sure you're drinking water, and then stay caffeinated wherever you need to be. You don't want to be that student who's like hypoglycemic in the OR and then passes out. You want to take care of yourself. And so you could keep, be enthusiastic so you continue to have that great attitude and do well.
And real quick, so of course I thought of this afterwards too. And this jumps off a little bit of what Emil brought up. And this is really important. Find something that brings you joy, whether it's reading a book that has nothing to do with orthopedics, or if it's going for a walk, or if it's lifting weights, or if it's talking to your best friend. Don't try to maintain that at least a little bit during these rotations, because that will help you build those skills, because residency doesn't get that much easier. And being able to continue those things will help you progress through residency and help you take care of yourself, because you can't take care of others unless you take care of yourself. That was very medicine-y.
Well, that officially wraps up our panel on excelling in the clinic. Thank you so much to all of our amazing panelists, and thank you as well to all the attendees for spending your Sunday with us.